Hi, good morning. And before we start with the panel, I would like to call upon stage our esteemed panelist, Dr. Ayushi Asawa, Dr. Ruchi Thakur, Dr. Vandana Khanejo, Dr. Sushma Rani, Dr. Rahul Argade, Dr. Mansi Sharma, and Dr. Madhvi Bahulikar.
Introduction.
ये लगा सकते हो या फिर ये
Good morning.
कर दो.
ये तो एक आवाज. Good morning and welcome to the 37th installation CME. We start with the first session, which is panel discussion on hypertensive disorders in pregnancy, or HDP. My dear panelists, don't be disheartened by the empty chairs. I took part for the first time in a panel discussion 40 years ago, when there were 5 panelists on the stage and only 3 in the audience. One of them was my wife. So today the situation is much better, so we'll go ahead with that. Hypertensive disorders in pregnancy, as we know, is not a single disease entity, but it is a spectrum of disorders, at one end of which is a chronic pre-existing hypertension, and at the other end, a very complex multi-system disorder like preeclampsia, with its dreadful complications like eclampsia, HELP syndrome, and various other cardiorespiratory and renal disorders. Now, for all of us obstetricians, maternal and perinatal mortality and morbidity is a major concern, and HDP is one of the giant killers, responsible for about 20% of the maternal deaths. In spite of increased number of hospital deliveries, the death rate has remained unchanged and not taking into consideration the underreporting. So we are here today to discuss this important topic with this erudite panel invited by the organizers. Considering the vast expanse of the topic and the time constraint, we have decided to focus mainly on the management and clinical aspects. So, and I wish to tell you that earlier, for many decades, we would depend on the white man's statistics. Whatever the people from US and UK would tell us, and we would believe it. Something done in Scandinavian countries and something done in Africa and Egypt. Now, thanks to Justice India, ICOG and FOXI, they started the National Eclampsia Registry way back in 2013. And so we have our own statistics, which we can reliably quote. Secondly, they came up with the good clinical practice guidelines also, which we have made the basis of our today's discussion. So to start with, let us make a quick introduction of ourselves, just one line or two. I am Dr. Charuchandra Joshi, past president of POGS.
I am Dr. Pankaj Sarode, past secretary of Dr. Charuchandra Joshi.
Hello. I am Dr. Ayushi Asawa, practicing at Alliance Munod Hospital and KM Hospital.
I am Dr. Ruchi Thakur, head of unit and associate professor at BJ Medical College and Sassoon Hospitals.
I am Dr. Vandana Khanejo. I am a gynecologist at Jahangir Hospital.
I am Sushma Sharma. I am a professor at MIMER Medical College at Talegaon.
I am Dr. Mansi Sharma, consultant at Manipal Hospital, Pune.
And she is a neonate in POGS managing committee.
I am Dr. Madhvi Bahulikar. I am a consultant at Dinanath Mangeshkar Hospital.
I am Dr. Rahul Argade. I am a consultant obstetrician and gynecologist.
So welcome all of you. I request Pankaj to start this.
So just for the knowledge of audience, we have no PowerPoint presentation this time. As moderators, we are just going to shoot questions to our panelists, and we expect them to answer what they practically do rather than going for some kind of guidelines. So let us start with a definition of hypertension. So Ayushi, can you define, how do you define hypertension in your patients?
Yes. Hypertension in pregnancy, that is gestational hypertension, is defined when blood pressure taken appropriately is more than or equal to 140 by 90 millimeters of mercury, and without proteinuria, and in preeclampsia it is associated with proteinuria and multisystem involvement.
So any patient who has blood pressure more than 140/90, you will define it as a hypertensive patient.
And before labeling the patient, we would like to
Take two readings in a gap of 4 to 6 hours.
Okay.
And now, what is the magnitude of this problem, globally as well as in Indian scenario? Rahul, if you can comment on it.
Despite of all the advances made in antenatal care and hospital deliveries, as sir has rightly pointed out, the number of deaths have gone by 30%, but still they remain quite high. And especially in Indian scenario, I think the percentage is about 10%, but fortunately the rate of eclampsia has come down. But as we know, preeclampsia and PIH, they are basically at huge at the early, like 18 to 20 years, and late pregnancies. So with advances with ART, we are getting a lot of older primees, and also due to pandemic, the number of underage marriages has also gone up. So we are expecting to see a lot more patients with hypertensive disorders.
So it is added to the list of existing risk factors.
Yes.
So the incidence is very high, and probably the most dreadful complications which every obstetrician is worried about.
Yes.
And
the death rate has gone by almost 30%, but still it remains fairly high.
Correct. Even in advanced countries, it is the second largest cause of maternal death. So that reflects how important this problem is. Now, Ruchi, can you tell us whether every patient who has blood pressure more than 140/90 can be categorized as just a hypertension with pregnancy, or there are subclasses of these patients?
There is an entire spectrum, as we all know. The first thing is gestational. It could be gestational hypertension, and as Joshi sir pointed out, it could be a pre-existing hypertension as well if it is detected before 20 weeks of pregnancy. Then in the spectrum is preeclampsia, which is hypertension more than 140/90 along with proteinuria and signs of end organ damage. And after that comes eclampsia, where we see convulsive disorders in pregnancy, in preeclampsia. Besides this, we also classify it as non-severe hypertension and severe hypertension. Non-severe is the cutoff limit is 140/90, and severe is when the systolic BP is 160 and the diastolic BP is 110. And as he rightly pointed out, there is early onset and late onset preeclampsia as well. So this is the entire spectrum.
Very good. Earlier during my student days, we used to have mild, moderate and severe. So moderate category, because it made no sense as far as the management was concerned. So that has been taken out, and is non-severe and severe. That is much more useful. Now, Sushma, let me ask you. This is a dreadful condition. So it would be better if you have something in your hand to predict it. So is it possible to predict the condition? As soon as a pregnant woman comes in, I would like to know whether she is she likely to develop hypertension or preeclampsia or whatever. So can we predict it?
Lots of work, sir, has been done on this, including by the GESTOSIS chapter also. And it's very heartening to know that there are a lot of predictive tests which have come up. The simplest of them being the GESTOSIS score, which includes certain factors, and they don't need any intervention and can be done just by means of a questionnaire kinds. And they have made it very simple. It includes the extremes of age, certain past history, like pre-existing diabetes, or if the lady had PCOS, or if the pregnancy is a result of IVF. There's a huge list. It's very readily available. It's in the GCPR, as well as if you just type GESTOSIS score. And it's very simple. If the score is more than 3, the lady is at high risk for getting a preeclampsia. Having said that, there is also a lot of other type of tests which can be done for prediction, which include lab tests as well as imaging.
To which we will come later on.
All right.
So, but how reliable are all these tests? As a general statement, what would you say?
Well, as a general statement, I would say that the combined tests could predict, they are more specific rather than sensitive.
Okay.
So the negative predictive value is higher than the positive predictive value.
So, Dr. Vandana, now since we are talking about predictions, we will come to the predictive parameters in detail, laboratory test and imaging techniques. But in our clinical setup, when a patient walks in, are there any parameters which we can find out through examination and history, which will tell us that she is at higher risk of developing hypertension or preeclampsia?
A very simple and a very good way of judging who is at risk of preeclampsia or eclampsia is the gestosis score. It divides, based on history, it divides all pregnant women into 3 categories, and they're given a score of 1, 2, and 3. 1 would be things like maternal extremes of reproductive age, so age less than 17 or more than 35 years of age at conception. And it also would include primiparity, a shorter duration of exposure to sperms, for instance, in condom users, or early conceptions immediately after marriage, even a change of partner. And it would also include things like, so these are the minor risk factors. And there's a huge list, of course, which is on the Gestosis site, and it's available as a software for easy use. And so these are 1. 2 would be so the BMI less than 30, more than 30 would be included in 1, and more than 35 would be given a score of 2. So again, multifetal gestations, obesity where BMI is more than 35, a history of gestational hypertension in a previous pregnancy, certain gestational diabetes, some other medical disorders are given a score of 2, and a score of 3 is given to women who have a history of APLAs, SLEs, rheumatoid arthritis, so autoimmune disorders, thrombophilias, acquired or inherited thrombophilias, and a history of diabetes, that is pre-gestational diabetes. Then a family history of gestational hypertension in a mother or a sister perhaps. Those sort of factors are given a score of 3. Now there are about 25 to 27 risk factors. Based on the score, any score more than 3, a 3 or more, is called a high risk situation. Now these women have to be monitored very carefully. In an OPD setting, a blood pressure record should be taken at every visit so that this scoring is done and modified at every visit.
Right.
So then there is, of course,
so every time one has to be vigilant with all these factors in mind.
Okay, so clinical factors, some of them are very high risk clinical factors, some are not so high risk, but total aggregate score must be taken into consideration. Now next question, Manasi, I'm going to put you a very simple question. What is the accurate way of recording blood pressure?
Sir, accurate way of recording blood pressure is patient.
In a pregnant woman?
In a pregnant woman, patient should be in sitting position at the level of the heart. Patient should be in a sitting position at the level of the heart. The cuff which you are using should be adequate for the patient. The circumference should be 2/3 of the arm circumference, not should be loose or either tight. Patient should be in the resting, patient should not be in an anxious anxiety state, it should be absolute in the resting state. And after rest, then only you are supposed to take the blood pressure.
Which machine would you prefer?
Mercury speedometer.
Left arm or right arm?
So left arm.
Why? See, it's a very popular misconception that since left arm is closer to the heart, but it is not so. Both the arms are equal. As long as you take it, don't take it on a leg or something, it is reasonably accurate. And so it must be a snugly fitting cuff of a proper size. And the mercury, in mercury manometer, the baseline of the mercury should be at the level of the heart. Supposing I don't have a mercury manometer, what will I do?
Sir, ideally it should be mercury. If you don't have, you can still use another
aneroid type,
Right.
but it has to be properly calibrated from time
yes,
to time.
Yes.
Okay. And supposing you get a reading of something like 150 by 100, what will you do?
I would still repeat it after 4 to 6 hours to confirm.
And make sure that it is taken in better or more ideal resting conditions. In a sitting position, if you want to take it in a recumbent position, it should be a left lateral position, especially after 20 weeks of pregnancy. Very good.
Sir, I would like to add here a little small point that these mechanical machines which we get for BP reading, they tend to give us slightly higher reading. If I do get something like this, I would make sure that I will arrange a mercury.
That's why calibration is important.
You get a proper reading manually.
There is practically no comparison. Mercury is the ideal this thing. But, okay. Madhuri, tell us about proteinuria, which is the essential component of diagnosis of preeclampsia, or in fact it would differentiate between gestational and chronic hypertension and preeclampsia. So, what is proteinuria, how we estimate it, what is the significance?
So presence of protein in the urine. The practical test that everybody does is the dipstick test, which can be done very quickly, easily in the OPD without any time lag. So the dipstick test showing more than 2+ proteinuria is called significant proteinuria. If you want to confirm it with a lab test, then protein creatinine ratio, which is more than 30 milligram per millimole. And the gold standard is, of course, the 24-hour protein collection, but that is practically very time consuming, and even if we are using just a dipstick test also, it is enough. Once you get a more than 2+ proteinuria, no need to keep on repeating it. You can label the woman as preeclampsia. But if you get a negative, then each visit she should be repeating.
In a known case of preeclampsia, if you get 2+ on a dipstick or more than 300 milligrams for 24 hours, you rightly pointed out that there is not much of a need to repeat it. Why?
The quantification will not change.
The prognosis does not depend on the quantity of proteinuria. It labels the patient as preeclampsia. Very good.
This 2+ dipstick method, what does it reflect into? The amount of protein in urine?
30.
300.
Same as 30.
30 milligram you're saying. Okay. And is proteinuria essential component of diagnosis of preeclampsia? And then by modern classification and definition, how do you define preeclampsia?
Sir, proteinuria is not an essential component. Earlier we used to say that proteinuria has to be there to define preeclampsia, but nowadays, according to recent classification, even if proteinuria is not there, if fetal growth restriction is there, or any other component of cardiovascular or neurological element is there, it can still be classified as preeclampsia along with hypertension.
So it can be considered as a variant of preeclampsia in absence of proteinuria, provided there are systemic manifestations or
as well as
deranged
growth
laboratory
signs of other organ involvement, since it's a multi-system disorder.
Okay. Now, like any potentially serious disorder, we are first interested in prediction of the disease. If for some reason accurate prediction is not possible, we will try and at least prevent it. And if even prevention is not possible, we will try and detect it as early as possible so that we can prevent it from going into complication stage. So coming to the prevention part.
Pharmacological prevention to Sushma.
Yeah. So what is the role of aspirin? Now tell us everything about aspirin. How does it act? What is its role in prevention of preeclampsia? What is the dose? When to start it and when to stop?